మూడున్నరకే.
Hello, sir. Not able to audio.
Session will start at 3:30 p.m.
Okay, thank you, madam.
Incoming voice call. Hello. Good afternoon. Satyabram? Sandmaid. Yes, ma'am. Tell me. Okay. Sorry, Satya. I forgot. uh, I'm doing another work. Where you have joined, right? G. Yes. I add as a co-host. Yeah. Thank you. Thank you for reminding. I actually forgot. Okay.
Lalit, you are not audible.
Yeah. Good afternoon, everyone, and welcome to Ipc Master Class 5 and Session 3. So we are really very happy to see all of you once again attending the session 3 of IPC Master Class 5.0, and wish you all a very happy Diwali. I hope you all are enjoying Diwali and having a safe and festival of lights. So with this, I go on to begin the session. And so this session is for evidence-based practices in dialysis room for infection prevention and control. And the session will be taken by Dr. Muhammad Shoaib Ahmed Khan from Medicover Hospitals. But before that, I would like to introduce our session chair, Dr. Ranga Reddy Buri. So we have Dr. Ranga Reddy with us. So just a small introduction about our session chair. Dr. Ranga Reddy Buri, he is a physician and a public health specialist and social entrepreneur with business interests.
Mr. Lalit, thank you very much. I think that would be sufficient so that we can save time and deliver more on the program. Thank you so much.
So handing over the session to you, Doctor, all yours.
Yes. Thank you very much, Mr. Lalit, for that very kind introduction. Today, as Mr. Lalit has mentioned, we are coming to the mid of series where of this season 5, which is named as prioritizing evidence-based infection prevention measures for improving the quality of care. First 2 sessions, I hope you have enjoyed. From whatever feedback we have received, I think it had been quite impactful. Both Dr. Nirav, Pandya and others, have delivered a fantastic feast, academic feast, and Dr. Jaya too has delivered. Although there was a little bit of technical glitch, I think ultimately that has worked out to be the most important session in terms of the delivery, also in terms of the interactiveness. I think the session went on for almost 2 hours. That shows that how much of response it has evoked and how much of importance it had been for all the participants. I thank both of them, and today we have wonderful presenters, Dr. Muhammad Shoaib Khan. I will come back to the introduction a little later, and also Mr. Mir Muhammad, who is a dialysis technologist with almost two decades of experience in terms of dialysis and dialysis related matters. Coming to the theme, today we are going to talk a little specialized topic that is about dialysis, and most of you know that that dialysis has become something which has become very important in terms of saving the lives of the people. And if we look at the global burden of the disease, about 1.4 million deaths, that is a staggering number. I never imagined actually that would be the number from which the people are dying in terms of the CKD. CKD is the chronic kidney disease. And we all know that it is disproportionately impacting low and medium income countries, where both prevalence and the deaths due to CKD are significantly higher than in the so-called developed countries. It is increasing globally, due to the factors such as obesity, hypertension, diabetes, and other chronic diseases, which are having actually impact or the attribution to this meteoric rise in terms of the prevalence of this CKD. When we talk about the burden in India, at least I could not find reliable numbers, but the approximate prevalence of CKD in India is considered to be around 800 patients per million population, and the incidence of end stage renal disease, or it is also called as ESRD, is 150 to 200 patients per million population. And there is again, when we look at India, there is a significant rise in terms of the prevalence, and almost like 38% increase in the proportion of the deaths are attributable to kidney failure. If you take the numbers between 2001, 2003 to 2010 to 2013, that makes actually situation quite complicated. But luckily, I think in India, the number of nephrologists and the hemodialysis units and the dialysis stations, all of these numbers are going up, which are providing a great service to all the CKD patients. At least 200 transplant centers are there, which are providing much needed breather for those people who already have lost the hope of living. So with all this, there are other significant factors, what makes the hemodialysis and also the peritoneal dialysis as a little complicated is that the cost. Luckily in recent times, several states and also the central government and several private chains like Nephroplus, Davita, and other centers have come up, which are providing kind of affordable dialysis, both hemodialysis and also the peritoneal dialysis, making a little easier for those patients who are going through already a difficult situation. But despite of all those things, I said, even the government sector, if you look at Telangana government itself, has established several hundreds of these dialysis centers across the state, including in the rural areas. But the significant problem, what we have heard from most of the patients and also the care providers and also the nephrologists themselves, is that while we have improved our technology, while the access has improved, there is a little problem in terms of the rate of infections among the dialysis patients. That is precisely the reason this session was organized especially for those specialists and those people who are working around the dialysis, so that the healthcare associated infections which are on rise during the dialysis can be contained, and so that we can reduce the risk of infections like the sepsis, bacteremia, the bloodstream infections, even the pericarditis, etc., among the dialysis patients, which is happening like a very frequent procedure nowadays. And just to give a number, apparently about 3.5 lakh dialysis sessions are done in India on monthly basis, with around 20,000 dialysis machines and 18,000 dialysis beds does this job very well. Without much ado, now let me introduce the speakers of the day. Dr. Mohammad Shoaib Ahmad Khan is a good friend. He has done his MBBS, MD, DMB nephrology and ECE nephrology from Europe, and he is practicing currently as consultant nephrologist and transplant physician at Medicover Hospitals, Hyderabad. He has over 10 years of clinical practice and has an expertise in kidney transplantation, multi-organ transplantation, preventive nephrology, critical care nephrology, diabetic kidney disease, hypertension management, AKI management, CKD management, etc., etc. He has several qualifications and several publications, both in national and also international journals. And he has, a person of his stature, definitely we expect to have many awards and accolades, which are plenty in number. I would not read out them for the paucity of time. And now, Mr. Akhil, can you please mute yourself? Yeah, thank you very much. And the second person, who is going to present and help us with this session is Mr. Mir Muhammad Ali. He is a dialysis technologist, having completed his Bachelor of Science and a certified hemodialysis technologist from Board of Nephrology Examiners, Nursing and Technology Inc. Had also qualified from Dubai Health Authority. He has been a tutor and instructor for dialysis technician course for quite a long period of time. And currently he is the head dialysis technician for ZVM Unani Multispecialty Hospital and also the Prime Multispecialty Hospital in Pune. So with those words, now first I would request Dr. Muhammad Shaib to take the lead and present. And today's session is going to be split into two distinct parts. The first part, about 40 minutes, Dr. Shoaib would be talking about the problems related to the CKD and also the dialysis. And Mr. Ali would be talking about the more technical issues related to managing the dialysis in the dialysis centers. With that, may I request now Dr. Shoaib to take over. Dr. Shoaib, the stage is yours.
Yeah, good afternoon, everyone. I'm Dr. Shoaib. So presently, I'm not able to share my screen, actually. Just wanted to put that thing on and get on with the topic rather than wasting the time, because I think everyone after Diwali festivities, a lot of sweets intake and all sugars must be high. We need to rest and all.
Maybe Lalit, would you be able to put the presentation and help Dr. Shoaib?
Yeah, I'll do that.
Been long time, Dr. Shoaib, since we met.
Coming open, that's what.
Yes, doctor. Here is the presentation and the stage is yours.
Yeah. Can't I share my screen?
But you are saying that it is not working out. That's why.
It's not working. Yeah. Okay. Sure. Then we'll go that way. No problem.
So you can try once again if it is not working.
The arrow is coming. It's just like you can't. You're not allowed to share your screen. Seems. Yeah. Now it's there. Yeah. Fine. Entire screen. Sure. Okay. Is the screen visible?
Not yet, doctor.
Not yet.
Sir, once you press share the screen, then you need to go to your presentation and open the presentation on your screen.
Okay. Sure. Yeah. Now is it seen?
Mm-hmm. No, sir.
Some option is coming. One second. Anyway, the option is there. Share. Yeah. Now it's there, right?
Yes.
Okay. So basically, just to be very fair and frank, presentation was made within a span of few minutes only, and this is just nothing but a revision of the routine standard infection prevention protocols laid down by the CDC, and obviously practical aspects we can discuss in the end, and I'll also mention in between whatever is there. So whatever we are practicing in 2022 is evidence based. Whatever data we will be talking about, it will be studied in lakhs of patients throughout the world. And as sir has told rightly that CKD burden is huge, And with this burden comes high morbidity and mortality. And it is just not the cardiovascular diseases, it is even the infections which is a leading factor. And infections being high is related to the low immunity of these CKD patients. So just to start away, these patients are very vulnerable to hospital acquired or healthcare associated infections due to various things like what I have just told. The immunity is less, and second, the close contact. These people who are on dialysis, these guys has to come every second day to a hospital, sit in the dialysis unit, sit in the waiting area, and not just the patient, even the attender who comes with the patient is at risk for acquiring various infections. And the more they interact with healthcare workers, the more chances of acquiring a transmissible disease goes up. And on top of that, the icing of the cake is the immunosuppressive state which they have because of the low nutritional status, followed by the chronic inflammation, which leads to the decreased immunity. So in 2012, the US renal data system has shown that the infectious complications, the data itself is not really there, but the most studied ones is the infection due to the catheters. Dialysis patients need blood to come out of their body, goes into a sort of an apparatus or a machine or a system where it gets filtered, cleaned, and back into the patient's body. This system requires a lot of blood to come. So the natural way is to create AV fistula, and it is covered by skin, infection rates comes down. The others are putting a plastic tube, be it a routine dialysis catheter in the neck hanging like an antenna, or a perm cath way little down. But again, it is a high risk for getting infections because it's a plastic tube. And these infections lead to a lot of economical burden. If you get one infection, you invest 1 lakh rupees just straight away. Presently, going to ICUs is like, probably nobody can afford all those such things. So the commonly seen infections, as I've just highlighted, is the catheter-related bloodstream infections. These are the number one, followed by bloodborne infections, that is related to the dry blood or improper cleaning of the dialysis machine, the linen, the atmosphere, everything is there. And sometimes dialysis patients unnecessarily, usually they don't have much urine output, but if they go to a hospital or sometimes a catheter, a urine catheter is placed, they are at very high risk of acquiring a COTY. Other infections are quite same when compared to other general population, but the incidence goes up because of the low immunity status. So what the CDC tells is that you need to really disinfect the system all along. Not only the critical, even the non-critical surfaces like the dialysis bed, chair, the surface of the machine should be disinfected, even if there is no visible blood on that. Because this will reduce the chance of hepatitis B virus infection, HIV virus infection, or various other infections which can survive on the surface for hours or sometimes days or weeks together. And as we have mentioned here, that the MRSA organism can be surviving on these packets for as long as 38 weeks. The packets where blood tubings are kept, where dialyzers are brought in, all those stuff can be infected. And vancomycin resistant enterococci can be there up to 6 months, especially most patients who are little elderly, having a frail condition, they may come on wheelchairs. And those wheelchairs are a high chance or a source where they can get infections. And microcuts are common in dialysis patients because the skin is wet, because they accumulate water in their body. And once water comes, skin is susceptible for micro traumas and micro injuries and cuts, which can again transmit VREs. So the most important thing is to prevent it. Prevention, this is the whole topic is about prevention, not about treatment. So when we talk about prevention, this is what we have been listening, I think, in almost all presentation. And this sticker is hanging on almost all hospital walls, thanks to the great efforts done by the infectious disease department throughout the world, probably. So there are 5 moments for hand hygiene. The first one being when you enter a patient or before seeing a patient, when you enter the vicinity, the first thing you have to do is take the hand rub over there, the sanitizer over there, wipe your hands and make sure they're dry. This is the most important thing because this is going to prevent you from transmitting infection to that poor being over there. And then the second step is you need to clean your hands immediately before assessing any critical sites, especially like if there is a catheter over there, a PD catheter, or any line is there. Before touching a patient, again, re-sanitize your hands. And the third one is being, if you are doing there is a high risk exposure to fluids like maybe blood or maybe like anything you are touching the patient, like sweat is there or some secretions or pus is there. The moment you remove your gloves, again you need to re-sanitize your hands. And the fourth one is while leaving the patient side after touching the patient or his or her surrounding, to protect yourself as well as the next patient whom you are going to see, for that person's safety also, you need to again sanitize your hands. And last is, even if you need to be so cautious, because one microorganism, COVID has definitely taught us that how deadly these microscopic structures can be, that even if you touch the surroundings like their bed or the curtain over there, including the case sheet, you need to definitely sanitize your hand again. If you follow these 5 steps of hand hygiene, the chance of spreading infection, the chance of acquiring infection, the healthcare worker as well as the patient, comes down significantly. After these COVID times, most people, especially patients, which I have seen in practice, have become very conscious about this. Even if you forget, the patient will remind you, Doctor Sahab, aapko karna hai dekho. So this is a growing awareness, I think, is the key, which will make not only patients attenders, healthcare workers, doctors, nurses, water boys, whatever, to improve their hand hygiene status and prevent the spread of infections. So the surface and environment disinfection, this is what you're talking about. Even if not the patient, all these things are labeled as infectious. And whenever you touch them, before touching them and after touching them, it's mandatory to disinfect your hands with a sanitizer. It may be the side table, the bed, the cardiac table, the sink, the furniture over there. If you're touching any of these things, you need to definitely sanitize your hands. So disinfection is incomplete with just cleaning. If you just clean, it will be not effective unless you really rub it off. Cleaning is just a pre-process of disinfection. You need to first make the surfaces clean and then you need to disinfect it. You can't just disinfect something whereas you are having big dirt particles over there. So what are the strategies to prevent the surface contamination? Cleaning is the most important, as we have just told. The physical removal of all material like dirt is there. Sometimes you really don't know. Some hospitals, even in the roof, there may be molds. The roof also has to be cleaned, and the walls over there, especially the corners where there may be, in our present situation, there may be insects or spider webs. Such things should be definitely cleaned on a regular basis. You miss a day or two, these things start coming in. So these things require friction. You need to use some cloth, something like that, to clean this away. It can be done with just routine water, or it can be used with disinfection. Followed by that is, you need to reduce the pathogen counts. First, you have cleaned the surface. You remove the macroscopic structures. The big structures, has been removed, which can be seen by the eye. And those organisms which can't be seen by the eye, we need to clean them with using disinfection by heat, chemicals, or both sometimes in certain situations. So the key considerations for surface disinfection are, first of all, we need to have a separate disinfectant for the skin and the patient supplies. When you're touching the patient's skin with the disinfectant, those antiseptics are supposed to be kept separately, and they should not be mixed from little bit more sort of an acidic solutions which are used for the surface disinfection. And we need to, before doing all this disinfection, we need to make sure that we ourselves are hygienic. Our hands hygiene must be performed, and we need to wear a glove and then use such disinfections. So use one set of cleaning cloths, or sometimes it can be a disposable cloth. Ideally, disposable is best, probably in a high resource sort of a setting. But if you're working in a sort of a primary healthcare center or somewhere in the peripheries, then probably reuse will be the only option over there, especially of cloths which can be used again and again. But make sure that this patient cloth does not goes to other patient areas and all. Probably for one area, one cloth can be kept and it can be isolated, which can be cleaned on a daily basis. And we need to clean frequently the high touched area which we just discussed, the red areas, the patient's desk, the patient's bed railings, and the furniture over there, and the cardiac tables over there should be cleaned more often. and we need to clean the top of the object first before going on to the bottom, and we should make sure that we should not soil the surfaces. And and as I've just told, never use the same cleaning cloth for more than one patient unit. And most important, even the bathrooms must be empowered, or all these things like tissue papers and soap must be there. If there is no soap, what can the patient do? He may just come out like that. So these things should be kept and must be followed on a routine basis. Probably a checklist should be stuck over there on the bathroom doors and all, whether it has been cleaned every third hourly, second hourly, whatever the institute's protocol is. Preferably every 2 hours, it will be better. And the coming to our core topic, how to disinfect the equipments in the dialysis unit, it predominantly consists of the exterior cleaning of the dialysis machines. So, and then followed by the interior cleaning of the dialysis machine. And we need to also monitor whether this disinfection happened or not. And there are certain other equipments which are used in dialysis machine, like where we store all these things, where the reprocessing unit is, from where these blood tubings are coming, from where these fistula needles are coming, from where the dialyzer is coming. These stores should also be disinfected. These are called the auxiliary equipment. Sometimes the monitors are also kept over there, and the sputum machine monitor probes should also be disinfected on a routine basis. So what is the IPC approach in our dialysis unit? So the item is taken into individual dialysis patient, should be disposed after use. So immediately after using a certain thing, it should be disposed in the appropriate colored bin. And the non-disposable items that cannot be cleaned or disinfected, like the adhesive tapes, the cloth covers, BP cuffs, they if possible dedicated for a single patient. Otherwise you have to disinfect it as long as it is compliant. And the external venous and arterial pressure transducers, which we use, which is called the protector, the small thing which we use in the dialysis machine, which is useful while checking the blood flow and suction, it looks into those things, that should be changed for each patient, and that should not be reused. The internal transducer filters need not be changed routinely between patients, but that should be checked, and probably monthly can be changed. When reprocessing or disposing the dialyzer port should be capped and the tubing must be clamped. Of late, reprocessing of dialyzers has come down. In my state, Telangana, what the government has started is, they have started the single-use dialysis system, which has been running for more than the past 5 years successfully. And the transmission of infections has come down drastically. The quality of dialysis has gone up drastically. So reprocessing is still done in certain low economy sort of hospitals or in the peripheries, and this reprocessing must be done very carefully. This is a potential source, especially where transmission of infections can happen. And second thing, even the heparin bottles, while doing a dialysis, blood comes out of the body and an extracorporeal circulation. Here the chance of blood clotting goes up. To prevent that, we inject heparin in the patient's blood, and this heparin comes in vials. So the whole vial is not used for one patient, it is used for 2 or 3 patients. So this sort of a practice is also risky. So it's always good to dedicate one vial for one patient and use it for him in the subsequent 2 or 3 dialysis which he will be coming. And the gowns and gloves should also be worn and should be discarded as and when it's required. So all equipment, including the front of the dialysis machine. The machine may look clean. As we have just discussed, cleaning is just a process from where disinfection has to go ahead with. So the dialysis machine, even if it is untouched by the patient, it should be considered contaminated, and it should be cleaned with the disinfectant immediately after the dialysis session. And the non-disposable instruments like clamps or scissors, which has no contact before the mucous membrane, may be contaminated. So these things should also be immediately sent to the sterilizing unit in the hospital where ETO is being performed. And to facilitate the thorough cleaning of the hinges and joints, these instruments must be submerged in that enzymatic detergent and rinsed thoroughly and soaked in an appropriate disinfectant according to the instructions given by the manufacturer. Typically, a low-level disinfectant, unless visible contaminated with blood, then we need to use tuberculosidal disinfectant. The alternative would be to send the instruments, as I have just told, to the sterile processing unit where ETO can be done. When coming to infections, most infections, as we are all focusing on, is to prevent, and with prevention, the immunization has a major role. So we should make sure that each dialysis unit patients should be vaccinated against specific infections which are at high risk. For example, because dialysis unit is a closed atmosphere, people are sitting in the room for 4 to 5 hours. One guy in the corner is coughing, some guy over there is breathless, and a stable patient is there. This person can acquire infections. So, and when if somebody coughs and goes, that organisms can be suspended in the air for hours together. So, preferably, all these patients should be vaccinated against pneumococcal infection, and probably the PCV13 is the one which can be given once in 5 years, that reliably reduces the infection of pneumonias by pneumococcal organisms. And influenza, every year a new vaccine comes. In India, we should use the Northern Hemisphere vaccine because we fall above the equator. A Northern Hemisphere vaccine, the latest one has just come last month, and not only patients, even all healthcare workers should be taking the annual influenza vaccine to reduce their time off work, coughing and sneezing at home. The other infections which are bloodborne are hepatitis B virus. Hepatitis B virus infection, it was initially a big hazard in healthcare, and it still remains to be a significant one until this vaccine came out. And prevention is like 100%. No vaccine has given such success rate which hepatitis B vaccine has given. If you have a titers more than 10, there is almost 0% chance of you getting hepatitis B vaccine, hepatitis B infection, even if that virus is injected into your blood. So we should make sure that these vaccinations are given to almost all the patients. The dosing of giving hepatitis B vaccine is not the same as given to the general population. General population will require just one dose today, another dose after 1 month, and then you give a booster dose at 6 months. Whereas in dialysis patients, the inherent low immunity in these patients prevents them to acquire the adequate titers. Therefore, if you diagnose a person to have chronic kidney disease, the earlier you vaccinate these patients, the better. In a normal individual, if vaccinated against hepatitis B, the titers remain high for more than 25 years. That's the data. I got vaccinated in my internship, still my titers are more than 100. So probably the dialysis patients, they are having low immunity. These titers starts waning off over a period of time. The titers goes down. So monitoring of vaccinated patients who have been done in CKDs 2, 3 or 4 should be done on annual basis. And if you find a titer less than 100, it's always preferred to give a booster shot. And in case it goes less than 10, then you need to revaccinate. The vaccination schedule as shown in this slide is that you need to give double the dose. It is not just 0.5 ml in one deltoid. It's supposed to be given 0.5 in one, 0.5 another one, double dose, that is 1 ml. Intramuscularly in the deltoid, it should be given on day 0 after 1 month, and one more we need to give at 3rd month, and then at the 6th month. That's the dosing, 0, 1, 2 and 6. So this vaccination will give the adequate titers in dialysis patients. Second is infections happens not only by touching or something like that, it even happens by injecting stuff. So, and it happens by medications administration. So aseptic technique must be always followed while handling a patient who is having low immunity like a dialysis patient. So we need to perform our hand hygiene before accessing the supplies, handling the vial and IV solutions, and hand hygiene is mandatory even before administering the medications. And all aseptic techniques must be used for especially parenteral medication administration, because one bacteria goes in the blood, it can be detrimental sometimes, especially while checking the GRBS. When you check their glucose, it's a bedside procedure. We need to be very careful that we are not supposed to transmit infection to the patient. And IV medication should be prepared in a clean area away from the patient treatment area, and that should be made, reconstituted and brought and then given to the patient just to prevent the contamination. And all open vials, IV solutions, if not used fully sometimes, should be discarded appropriately in the appropriate bin, sharps into the white bin. So these are the key action areas where we can look into to prevent these infections? First of all, we should look into ourselves. We should educate ourselves what we are doing right now, and we should train ourselves repeatedly, because what we get educated, we may forget in some course of time. So we need to keep on revising it, as well as we need to build a team who understands that the patient's health is important, infection prevention is important, and we should always assess our capability. And if there is any issue, it should be made sure it is reported, because it should not be like, many incidents are happening, it's not coming to our eye or to our notice, and eventually something big happens sometimes. So even the smallest of the smallest thing should be reported. An incident reporting system must be made, and we should learn from that, not humiliate the person who has done the mistake. The product quality safety must be assessed. In the medicines, the expiry date must be checked, the right patient must be checked, the name labeling must be checked, whether it should be given IV, IM, sub-Q must be checked, and it should be given appropriately to the appropriate patient. And like especially the patients and public awareness is going high after COVID. Significantly, what I have seen in practice is patient is very conscious whether such things, infection prevention protocols have been followed or not, and this has reduced infections significantly. Probably awareness to the masses is also a very important factor in reducing this preventable infections, which can be just avoided by following simple hand hygiene and proper administrative techniques. So this is the standard precautions that hand hygiene, obviously on the top, that is the king of all. And then you have the personal protective equipments. PPE has been in high demand of late. We should prevent ourselves, especially before doing any procedure, especially into the blood-borne major veins, artery, or the lumbar canal, and the patient position. Infection safe injection practices must be used, and we should teach the patient the cough etiquettes, the respiratory hygiene, and we should make sure that the equipments are clean between two patients. The textile and the laundry must also be cleaned on a daily basis, washed with soap and detergent, and we should always prevent sharp injuries, because sharps must be disposed very meticulously in the appropriate bin, and we should make sure that this does not infect not just the patient, even the healthcare workers. If you're doing a procedure, you have used the scalpel or you have used the needle and kept it open, it may prick the ward boy who is going to throw it in the dustbin, and the person who is going to take the bag and throw it somewhere else. So these all are potential people who can get infections, so it must be sent in the appropriate bin. The technician safety is also important. So lab coats are crucial. Of late, probably lab coats have gone down and scrubs are coming into the picture. So whatever it is, they should be of regular cotton, non-fluid resistant, are to be avoided, because they are not considered as personal protective agents, but they definitely prevent infection to the opposite party, because these are cleaned on a daily basis and not used. Lab coats, they're in the office, you're using it, and then it's going on. That's another source of infection. So whenever accessing a patient who is in isolation, then a fluid resistant gown must be used, and it should be discarded appropriately, and it should be removed. It should not be reused. If you're going outside, taking out the gown, hanging it, again coming back after lunch, again putting on the same thing, may be dangerous. It should be always a new one every time. Full isolation or the fluid resistant gowns should be worn when caring for an isolation patient, especially who is having hepatitis B virus, and we should cover the arms and be closed in the front. That's how the gown should be, and it should be worn when there is a likelihood of blood contact, especially when initiating or removing a patient from hemodialysis, and it should be worn when there is a likelihood of body fluid contact, especially person who is having a diarrhea or uncontrolled secretions or a draining wound, that should be there. And even these gowns which are water resistant or fluid resistant should be used while reprocessing the dialyzer. Gloves should be worn whenever caring for a patient, especially the clean ones. We do not always have a sterile one unless accessing a high risk area, and these gloves will prevent the chance of getting infection to you, as well as infecting the medical equipment around the patient surrounding, like the dialysis machine, dialyzers, or blood tubings. And these gloves must be worn while cleaning the machines or the the working station or wiping of blood or body fluid spills which happened over there during a dialysis session. And they should be changed immediately. The moment you remove the gloves, you need to disinfect your hand once again, and then go to another patient, put on another glove, and then so on it goes. And it should always be changed after cannulation. It should not be you have worn a glove, you have cannulated the patient, kept the glove over there, and then while decannulating, the same glove is going on your hand again and decannulating to that patient. This is a technique used in most dialysis centers, especially in the peripheries. It's a wrong technique. It should be avoided. Gloves should be removed and they should be discarded immediately. If a person has cough, we really don't know, immunosuppressed patients, not just a routine viral or a pneumococcal infection, they may even have tuberculosis. Always we need to put on a mask on the patient as well as ourselves. So face protection is important, especially a coughing patient should be put across in some corner area, preferably in the last shift, and he should be given proper face protection. Even the person who will be reprocessing the dialyzer or cleaning the equipment should be using a face mask. That is to prevent any droplets going in his mouth or something, and it can cause infections to him itself as well as poisoning sometime because of these sterilants. So this is what we just discussed, that this slide just shows that gloves are required for all these things, and gown for home, lab coat for home, and mask and eye. The more the better is. So transmission based precautions, airborne precautions, airborne diseases, as we have just discussed, not just varicella, even tuberculosis is a major threat, and they can be airborne for up to 2 hours. So we need to identify the patient early, suspect the disease, and mask him immediately. The less the things, the microorganisms go airborne, the less the chance of transmitting infection to others over there in the dialysis unit as well as the staff working over there. So now comes the droplet precaution. Illnesses transmitted by the large respiratory droplets includes, like, there are various diseases like pertussis, influenza, mumps, diphtheria, mycoplasma, adenoviruses. But most importantly, if you have covered them with the mask, the chance of getting all these infections come down. And we need to teach the patient the respiratory hygiene as well as the cough etiquette, that how to cough into the elbow, and using not just a face mask. If it's not there on the time, then at least having a kerchief or a cloth to cover the mouth with. And if hospitalization is required, this patient should be kept in a separate area, at least 6 feet from other patients, to prevent infection to the poor fellow over there next to him. Contact precautions are also important, and a routine contact precaution are not required in HD units for patient infected or colonized pathogen bacteria. So these are the things which are important to be noted. So to prevent the healthcare acquired infections, we need to really check the viral titers, especially of hepatitis B. If it's not adequate, like it's less than 100, better to give a booster. Less than 10, revaccinate them all along. And we need to make sure that we have a dedicated machine for hepatitis B virus positive patients, because this is a highly virulent virus. However, most guidelines, including the KDOQI guidelines, do not recommend having a dedicated machine. But what we have found is, if you have a dedicated machine, the chance of transmission, infection to others comes down. Although it's a closed process, but there are various factors to be considered, and a dedicated machine reduces such infection. And if preferably to have a separate room or separate area where a positive machine is kept. And the dialyzers used for such patients should be discarded immediately. Reuse can be detrimental, because even a single drop in the washing base sink or the area over there can infect other dialyzers and can cause transmission in other patients during dialysis. And the person washing and reusing should be fully covered with a mask and even have eye protection, including the gloves. And this should also be followed even while cannulating and decannulating. We never know, if there is a spill of blood, droplet or something like that, the person may contact a bloodborne infection, that is like hepatitis B. And we need to have systems where we will be checking patients' viral status once in 3 months, like hepatitis B, HCV, and HIV. The chance of getting an infection from HIV exposure rate is around 0.2 to 0.4% From HCV infected patient, the chance of an infection by a prick is around 1%, whereas exposure to hepatitis B virus infection, the chance of an HBV infection is around 30%. But just a point to note here, once I asked the dialysis nurse, whom are you comfortable dialysing, HIV, HCV or HBV? And the nurse very innocently told, sir, HBV. I told, but why? Such a high infection rate is there. So then she told, sir, I'm vaccinated. So it's very important for all healthcare workers to check their vaccination status where it is B virus. It's very virulent and it is very much preventable. So vaccination against hepatitis B is very important, not only in the patients, but also the healthcare workers. So the KDOQI recommends screening anti-HCV, HIV, HBCG once in 6 months, but in most centers in India, it's done once in 3 months. The respiratory hygiene is you need to cover your cough by probably cough into your elbow or a kerchief, and wash your hands with warm water immediately after coughing, using a soap or cleaning with an alcohol based hand cleaner. And washing hands is important by following all the steps. Now the vascular access. Hand hygiene should be performed prior to inserting using alcohol-based hand sanitizer, which is commonly available bedside, which has an alcohol concentration of greater than 60%. Sometimes soap and water can be used, but it becomes very cumbersome. So you can advise the patient before coming to the dialysis unit, please wash your fistula area, not only at home, morning, evening, even before coming, do an extra wash with soap, which is antimicrobial, and come to the hospital, where we can obviously use the alcohol-based hand sanitizer and start the cannulation technique. This is for the fistula, but if you are using a catheter like internal jugular vein HD catheter or a perm cath, while placing it also, it's very important we need to avoid the femoral vein. The area is dirty. The chance of infections is slightly more when compared to the internal jugular veins. And a maximum sterile barrier precaution should be used while placing the catheter, like having a cap, mask, sterile gown, sterile gloves. All these things should be used. And if you're using an ultrasound machine probe, we need to cover the whole probe with a plastic cover called a camera cover or ultrasound probe cover while placing it. Otherwise, the draping is a standard technique. It should be a whole towel. The hole should be as small as possible and exposing as less area as possible. And make sure you, while cleaning the patient before draping, you cover at least double the size of the whole towel. So this is a photograph that shows a person undergoing hemodialysis with one cannula in the mid arm and another near the elbow, just above the elbow, from where the blood comes out. The red one signifies blood coming out, goes into the dialyzer at the backside where that small tubes, whitish color is there. That's called a dialyzer, where the blood goes in and starts filtering and comes out through the blue one and goes back through the blue. That's the venous part and goes into the patient. So this is a closed process, but patient's blood is exposed to so much external surfaces. The chance of infections can be high. So hence hand hygiene and surface cleaning is very important. These are certain techniques which has been recommended while cannulating. So you need to always look into the catheter before cannulating, whether there are cracks in the tube, whether the caps are kept properly on the end, because when the patient goes home, it's not your area. Anything can happen to the guy. There may be children at home, someone may press it, or someone may pull it, and sometimes the catheter becomes old and the plastic can start wrinkling and can rupture, small cracks can come. So look into the side, look into the exit side. There should be no signs of infection, especially redness. Any pus should not be coming, and especially the perm cath cuff should not be exposed. It should be inside the patient's skin. If the cuff comes out, the whole purpose of that perm cath is over. So that catheter should be removed and another one should be placed. We should not attempt to again push the perm cath inside with the cuff going in. This may increase the chance of infection. If there are any of these things are not appropriate, immediately incident report must be made and it must be recorded, and the patient must be counseled what to do and the plan should be made. And not just looking, you have to even listen to the patient. So when you meet the patient, immediately ask while doing the looking part simultaneously that was there any fever, did the patient notice anything in the catheter, was there any ooze at home, or there was any redness at home, or something happened over there. If the patient tells no sir, all clear, then we can go ahead while cannulating or using the catheter. And when you, after cleaning, sterilizing your hands, putting on the gloves, you need to always feel whether there is pain over the catheter area or the fistula site. While pressing, if there is pus or ooze is coming out, or if the temperature over there is slightly more than the other surface of the patient's body, then we need to again think of a cellulitis or a local infection, and that should be treated and reported. So now coming to the fistula. Fistula is nothing but a connection made between the artery and a vein, so that the blood flow of the vein goes up, and which can be repeatedly cannulated again and again. Something just inferior to the fistula is a graft. If veins are not amenable, they are unlikely to mature, or we are in a hurry for a native access, then a arteriovenous graft can be placed. Shown in this photograph, the white color thing coming out from the red one, the artery goes into the vein. This is a plastic PTFE graft it will be, and it can be cannulated. It matures well, but again the infection rates are slightly more than the fistula. So before cannulating these things, skin preparation is very important. It must be cleaned with an antiseptic, preferably alcohol rub, which is 60% alcohol, or we can even use iodine solutions, betadine iodine solutions. So this algorithm just shows how it is done. We need to locate, inspect, and palpate the needle cannulation site prior to skin preparation. Repeat prep if the skin is touched by the patient or staff, but the cannulation is not complete. 1 second. एक second. Class 1 second. Okay. Sorry, it's my son. So repeat prep if skin is touched by the patient staff, and then wash the area with the soap, or like patient is washing and coming, we can use the antiseptic over the patient's arm with more than 60% alcohol or an iodine solution. If you are using iodine solution like the betadine, then we need to make sure that it dries up. We should give at least 2 to 3 minutes time, and then it should be used. These alcohol solutions are quite good, and they have a persistent antimicrobial activity in the skin for up to 48 hours. Because the patient is not anywhere cleaning his catheter at home, or fistula has not been cleaned properly, a regular thorough clean at the dialysis unit also can prevent infections at the fistula site. We need to rub it with friction for at least 30 seconds. Not very hard, but with some amount of friction it should be rubbed. We should wait for the area to dry. And then alcohol has a short bacteriostatic action, and hence it should be applied in a rubbing motion circularly from inward to outward for 1 minute immediately before cannulating, and then the cannulation process can be done after 2 to 3 minutes. Okay, clean gloves must be worn by the dialysis staff for cannulation. Yeah. So the permanent access fistulas or graft, the following principles support reduction of infection risk and should be included in education for dialysis staff and patients. Patients with a fistula should be taught first exercises to encourage fistula development. That is, you need to give them a ball and press it on the regular basis so that the vein is closed and the veins mature faster. The sooner the fistula develops, the sooner we can remove the dialysis catheter, either be it a temporary one or a perm cath. Skin around the access area should be kept clean and dry once the dialysis is started. The fistula or graft must be cleaned with soap and water prior to each dialysis treatment. Patients should be encouraged to check the access daily. Their patients must feel the fistula with the other hand, and if they have a thrill, then that's good. And they should also be accustomed to the feel of the thrill and how far the thrill goes. It should at least travel for at least 4 to 5 centimeters. Otherwise, the fistula may start developing some sort of a stenosis or a clot inside. And patient must be warned not to wear tight clothes, jewelry, watch on the fistula hand, and especially avoid sleeping on that access hand, because the venous return may come down and the blood may clot and fistula may go. Fistula is the lifeline of a dialysis patient. And patients, right, even before a fistula is created, they should be taught not to take any sample from that hand, not to give the healthcare worker any sample from the fistula hand. After the fistula has been made, then again they should be told. Sometimes some nurses may not know very good looking vein, and they may put a cannula or try to take blood from there. That can be very detrimental. It should be avoided. We should also avoid checking blood pressure on the fistula hand, and we should tell the patient not to lift heavy object. That is not more than 15 kgs. 15 kgs is one bucket full of water. That's the maximum weight a person can use who has a fistula hand. Otherwise, if you use more weight, what's going to happen? Aneurysms may happen. The veins may get much more encroached. Exit site dressing must be used. A dry dressing or a transparent dressing gives equal results, but a transparent dressing gives more power to the patient to look for any complication, any redness or any ooze inside. That's much preferred, but the cost also goes up. The published guidelines recommend changing the dressing every 3 days for gauze and every 7 days for a transparent. However, these patients usually come to dialysis unit once in 2 days, hence doesn't make much of a difference. The CDC in 2002 recommended that povidone, that is betadine antiseptic ointment, can be used at the HD catheter exit site after catheter insertion and at the end of each dialysis session. So the water and testing. In each dialysis unit, the RO is supposed to be considered the most important thing, because a dialysis patient is exposed to around 180 to 200 liters of water during one session of dialysis. And there are various guidelines which has come off late. The one is that we need to check the microorganisms colony forming unit. They should be less than 100 in any dialysis unit water, the RO water. And the endotoxin level should be less than 0.25 endotoxin units per ml. And even the concentrates, not just the dialysis water, but during dialysis we need to use certain, it comes in bottles which are non-sterile, which will be having acid and bicarb. So these things come separately, and these concentrates after mixed should be checked for presence of microorganisms. It should be less than 200. Endotoxin should be less than 2. The alert value is definitely half of that, 50% and below of that you should be alert. But what the guidelines has come is telling that you need to get alert even if it's 25% more. Like if you have a colony forming unit more than 50, you need to be alert. And more the water is exposed, for example, you do hemodiafiltration, more water is exposed, like roughly around 30-40 times it goes up. Then in such situations, the water needs to be ultra pure. And this surveillance must be done on a regular basis. Monthly cultures must be done, and daily endotoxin levels must be checked. Surveillance is defined as the ongoing systematic collection, analysis, interpretation, and dissemination of data regarding health associated events, and is used to reduce morbidity and mortality to improve. That's the definition. And it involves various processes. That is, you need to have your own standardized definitions, monitoring of the population at risk for infection, and you need to keep on analyzing the data. That's how important the reporting part is, and getting the feedback from the primary caregivers and giving the feedback to the appropriate authority who are leaders in such things like you guys over here. So in 2008, the ESRD, that is end-stage renal disease, Medicare, CFC required facilities, either hospital-based or freestanding, should include infection prevention control as a formal part of the quality assurance and performance improvement program. Off-late dialysis home. So these areas, there is no regulation on how to do, where to do, what to do dialysis. So probably more regulations are required in this area, where we can control stuff and which can help in more utilization of infection control policies and prevent the infections. Because if the machine is at home, machine is in transport, then the chance of infection going up is very high. So the trend presently in the market should be always analyzed, and we should always have a baseline information so that new recommendations can come up to minimize the infection transmission. And we should always encourage all dialysis patients to get immunized against preventable diseases and to prevent such issues in the future. Just to revise in short what we have covered very quickly: the environment cleaning, disinfection, equipment cleaning, hand hygiene, these are the most important thing. The first three are the most important thing. This is in our control, followed by patient education and employee education against infection, as well as getting them vaccinated, is very important. And monitoring our staff, how they are giving medications, from where the medication is coming, is very crucial. And there should be a regular surveillance of the dialysis water. Standards must be checked, and the standard of the bar must go up each year. And these quality improvement programs must be held on a regular basis. Just to conclude, hemodialysis patients have a unique vulnerability to healthcare associated infections, and a number of not just humans, environmental, procedural factors are related, which can increase the chances of getting infection in a patient who has a lot of comorbidities, especially a dialysis patient. Hence, establishing an infection prevention and control program in each unit individually, independently, under a doctor and a technician and a nurse. These three must sit on a regular basis every quarterly, analyze stuff, and try to work towards a better tomorrow. Thank you.
Thank you very much, Doctor. That was super comprehensive. I think there is no one detail which you have not covered. There is a lot of appreciation from the participants for taking them through the entire journey of the dialysis, and also giving the minutest details and the practical tips to enable each of the IPC practitioners to go back to their institutions and actually make a difference to those institutions in terms of infection prevention and control practices. Thank you so much, Doctor. Now, please stay on, because there are many questions.
Yeah.
I can see 20, 30 questions.
Yeah.
Please stay back, and now I request Mr. Ali to make his presentation. Mr. Ali? Mr. Muhammad Ali? Mr. Ali, are you ready? Mr. Ali, your screen is blank. It is black. And we are unable to hear you. Are you in there?
Yeah, he's there. I'll just present and he'll present it. So there's some issue.
Okay, no problem. Please. Yes, Mr. Ali, I think the presentation is put on and the stage is yours. Please go on. Yeah, I think there is some technical glitch. We expect Mr. Ali to join in a couple of minutes.
Yeah, we trying.
If it is going to take more time, shall we proceed with the question answers? With
Yeah, sir. I think that would be better, sir. Then we will connect after the questions.
Okay, fine.
Hello.
Yes, you're right. Please.
Yeah, this is Mohammed Ali. I'm a dialysis technician, dialysis trainer. So currently today I have to discuss on infection control and dialysis center. Right. Hello.
Yeah, please go ahead.
My voice is audible. Okay. Yes.
If you have logged in from two different systems, please log out from one.
Just a minute. Okay. So infection in dialysis patient. Okay. So infection. So first of all, we come to know that what is infection. Infection is the invasion of a host organism, bodily tissues by disease-causing organisms, and the multiplication and the toxins may produce. हमें सबसे पहले समझना होगा कि इन्फेक्शन है क्या चीज़ है. Actually, something I have to clear that. मैं बहुत कॉमन डिस्कशन करने वाला हूँ इस मौके पे, क्योंकि हमारे बहुत सारे जो टेक्नीशियंस हैं, जो हेल्थ केयर स्टाफ है, वो बहुत कॉमन लैंग्वेज समझता है, इसलिए हमको उन तक मैसेज कन्वे करना बहुत जरूरी है. तो इसलिए मैं बहुत कॉमन लैंग्वेज यूज करूंगा यहाँ पे, क्योंकि इन्फेक्शन असल में यहाँ से हमारा डिस्कशन एक्चुअली चालू हो जाता है कि व्हाट इज इन्फेक्शन. कि फॉर एग्जांपल इन्फेक्शन ये है कि जैसे आपके चेहरे पे अगर कोई पिंपल हुआ है, वो अगर इससे हमें समझने की चीज है कि वो क्या है. वो एक बॉडी का एक मेटाबॉलिक वेस्ट है जो किसी फॉर्म के अंदर बाहर निकलना चाह रहा है. फॉर एग्जाम्पल अगर वो जो पिंपल है वो फूट गया, कुछ उसको हो गया, ओपन हो गया. अब यहाँ पे हमें देखना है कि ये कोई इन्फेक्शन में कई तब्दील किस तरह से होता है. अगर कोई सरफेस, अगर हमारा हाथ है, कोई और कहीं पे हमने हाथ लगा दिया है, कोई चीज अगर उस पर कोई चीज लग जाती है, जैसे बाहर का एनवायरनमेंट लग जाता है, पोल्यूशन लग जाता है, तो वहां पे एक होस्ट माइक्रो ऑर्गेनिज्म आके एक इन्वेशन होने लगता है, यानी पनपने लगता है, जिसको कोई अगर बैक्टीरिया है, कोई वायरस है, तो जैसे अगर वो कोई उसको फ्लूइड मिल गया, कोई और उसको ब्लड मिल गया, तो वो वहां पे वो प्रोड्यूस होने लगता है. वो वहां पे उसको एक मीडिया मिल जाता है डेवलप होने के लिए. तो बैक्टीरिया को जो है सरवाइव होने के लिए उसे चाहिए कोई फ्लूइड या फिर कोई लिक्विड, जहाँ पे वो तो जहाँ पे जैसे भी मौका मिला बैक्टीरिया वायरस ग्रोथ होने लगता है, तो वहां पे वो इन्फेक्शन में जो है तब्दील हो जाता है. ये इन्फेक्शन होता है. हम बात करेंगे कि इन्फेक्शन डायलिसिस में किस तरह से होता है, क्योंकि डायलिसिस में मोर देन 36% पेशेंट ऐसे हैं जो ओनली इन्फेक्शन की वजह से उनके डेथ हो जाती है. मॉर्बिडिटी और जो मोर्टेलिटी का जो रेट है इन्फेक्शन के थ्रू, वो 36% अकाउंट करता है. राइट. उसमें जो मेनली जो लीडिंग कॉजेस है जो डेथ और मॉर्बिडिटी और मोर्टेलिटी का, दैट इज सेप्टिसीमिया, यानी ब्लड में इन्फेक्शन. एंड ब्लड में इन्फेक्शन जाने की वजह क्या है? बहुत सारे, देयर आर मेनी फैक्टर्स टू इन्वॉल्व इन टू बिकम ए सेप्टिसीमिया. ओके. सो जिसमें होता क्या है, सेप्टिसीमिया में कार्डिक अरेस्ट हो सकता है, एरिथमिया हो सकता है, इरेगुलर हार्ट बीट होता है, और जहाँ पे जैसे कि इन्फेक्शन है, यूरिनरी ट्रैक्ट इन्फेक्शन है, निमोनिया है, बैक्टीरियल इन्फेक्शन है, वायरल इन्फेक्शन है, और हेपेटाइटिस सी है, हेपेटाइटिस बी है, HIV है. तो ये सारे इन्फेक्शन हैं जिसमें जो टोटल नंबर ऑफ मोर देन 36% जो है मॉर्बिडिटी मोर्टिलिटी रेट ऑकर हो रहा है। और उसकी एक सेकंड सबसे मेन जो वजह ये होती है कि डायलिसिस पेशेंट जो होते हैं हमारे, वो सबसे पहले तो ये इम्यून सप्रेस्ड रहते हैं, जिनका इम्यूनिटी लो होता है। उसकी वजह ये है कि ये पेशेंट ऑलवेज जो है ये एनीमिक रहते हैं, क्योंकि किडनी का काम ओनली प्यूरिफिकेशन या फिर जो है बॉडी से वेस्ट निकालना नहीं है। किडनी के और भी बहुत सारे फंक्शंस है, जैसे कि रिमूव, रेगुलेट, एंडोक्राइन। डायलिसिस में हम जो कर रहे हैं वो रिमूव हम कर रहे हैं, क्या रिमूव कर रहे हैं कि एक्सेस वाटर है और एक्सेस फ्लूइड है और नाइट्रोजनस वेस्ट रिमूव कर रहे हैं। लेकिन किडनी का जो मेन जो फंक्शन है मेटाबॉलिक वेस्ट को सब्सटेंस बाहर निकलने के अलावा जो काम है वो है एरिथ्रोपोइटिन हार्मोन प्रोड्यूस करना, जिसकी वजह से बॉडी में ब्लड की मात्रा जो है इनफ रहती है। और ये किडनी माल फंक्शन होने की वजह से, एरिथ्रोपोइटिन हार्मोन सिक्रेशन न होने की वजह से बॉडी जो है वो एनीमिक स्टेट में चली जाती है। ये इसका मतलब होता है कि उसका एचबी लो होता है, ब्लड की कमी, जिसको हम कहते हैं एनीमिया। तो अगर आरबीसी है, डब्ल्यूबीसी है, प्लेटलेट है, हमारे बॉडी जो ब्लड के जो भी प्रोडक्ट्स हैं, ये सारे रिस्पॉन्सिबल है हमारे बॉडी के स्टेबल एनवायरनमेंट को मेंटेन करने के लिए, हेमोस्टैसिस को मेंटेन करने के लिए। जैसे कि डब्ल्यूबीसी है जिसमें न्यूट्रोफिल है, एसोनोफिल है, बेसोफिल है, जिनका काम है कि हमें हमारे बॉडी को इन्फेक्शन से दूर रखना। तो ऑब्वियसली जब एचबी लो होता है, ब्लड की कमी होती है, तो इनके अंदर जो है ये काउंट भी इनकी कमी या ज्यादा होती है, जिसकी वजह से इन्फेक्शन होने के चांसेस होते हैं ओनली बिकॉज ऑफ इम्यून सिस्टम इनका लो होने लगता है। और इसकी वजह ये भी है कि फ्रिक्वेंटली जो है डायलिसिस पेशेंट को कैथेटर यूज किया जाता है और नीडल यूज की जाती है, जिसकी वजह से जो है इन्फेक्शन के चांसेस होते हैं। और ये है कि जो कैथेटर होता है, कैथेटर जैसे आईजीवी है, सबके और फीमोरल है और पर्म कैथ है, सबसे पहले तो हमें इन जो कैथेटर जो ये टेम्पोररी जो एक्सेस हैं इनको समझना है कि ये क्या है। मोस्ट ऑफ द टेक्नीशियंस को ये पता नहीं होता है कि कैथेटर हमारे बॉडी में कहाँ तक इंसर्ट कर गया है। जैसे कि हाफ ऑफ द पोर्शन जो है कैथेटर हमें बॉडी के बाहर दिख रहा है, जिसको हम मेंटेन कर रहे हैं, और मोर देन हाफ पोर्शन जो है हमारी बॉडी के अंदर एंटर कर रहा है, जो बिल्कुल हार्ट के जो है के करीब जा रहा है। तो हाफ पोर्शन बाहर है, हाफ पोर्शन बाहर अंदर है। जो मैनिपुलेशन की वजह से बाहर की जो स्किन के ऊपर के जो बैक्टीरिया है, जो हमारे मिस हैंडलिंग करने की वजह से जो बैक्टीरिया है, जो वायरस है, वो स्किन के अंदर जाने के चांसेस ज्यादा रहते हैं इसमें। तो जिसकी वजह से जो है इसकी बड़ी वजह ये भी है कि मिस हैंडलिंग ऑफ जो है डायलिसिस कैथेटर्स। सबसे पहले हमें समझना है कि डायलिसिस कैथेटर को अगर हमें सही रखना है, सही उसको स्टेरिलाइज प्रोसेस से अगर हमें रखना है, तो उसके लिए हमें क्या प्रोटोकॉल यूज करने की जरूरत है। जैसे फॉर एग्जांपल के हैंड हाइजीन है, वेयरिंग ऑफ ग्लोव्स है और मास्क है, पीपी जो है इस्तेमाल करना, पर्सनल प्रोटेक्टिव इक्विपमेंट को हमें इस्तेमाल करना है, मास्क है, ग्लास है। तो मोस्टली ये होता है, यहाँ पे ये होता है कि एक तो पेशेंट्स अनअवेयर रहते हैं इन चीजों से, और डायलिसिस टेक्नीशियंस भी अनअवेयर रहते हैं। तो जहाँ पे अगर अनअवेयरनेस की बात आती है, तो डायलिसिस टेक्नीशियन को ही अगर पता नहीं है कि इन्फेक्शन के सोर्सेस क्या हैं, तो वो एक कैथेटर को सही से हैंडल करना उसके लिए मुश्किल है। इसलिए सबसे पहली बात तो ये है कि अवेयरनेस प्रोग्राम की जो है यहाँ पे बहुत ज्यादा जरूरत है, कि जहाँ जहाँ भी डायलिसिस के जो सेंटर्स रहेंगे, जहाँ पे डायलिसिस के जो यूनिट्स हैं, हॉस्पिटल्स हैं, और मोस्ट ऑफ द जो डायलिसिस टेक्नीशियंस है, हमें जो है अनक्वालिफाइड या फिर ट्रेन टेक्नीशियंस मिलेंगे। तो यहाँ पे अगर हम क्राउड अगर देखा जाए तो बहुत सारा क्राउड ऐसा है डायलिसिस के फील्ड में जो अनअवेयर है या फिर जो है अनएजुकेटेड है। तो जहाँ पे हमें फ्रीक्वेंटली जो है एजुकेशनल प्रोग्राम्स रखने की जरूरत है, जिसमें जो है हमें ये बताना है कि हाउ टू यूज कैथेटर का इस्तेमाल कैसे किया जाए, डिसइंफेक्शन कैसे किया जाए। जैसे अगर कैथेटर अगर होता है तो जैसे पर्म कैथ है, राइट, तो पर्म कैथ इसलिए उसको पर्म कैथ कहा जा रहा है कि मोर देन आईजीवी और मोर देन फीमोरल जो है उसको हम अच्छी तरह से इस्तेमाल कर सकते हैं, कि वो मोर ज्यादा सेफ है, राइट। लेकिन चाहे पर्म कैथ हो, चाहे डायलिसिस कैथेटर कोई आईजीवी हो या फिर फीमोरल हो, उसको सही से स्टेराइल रखना, उसको सही से उसको जो है हाइजीन रखना, ये हर हेल्थ केयर वर्कर की जरूरत है। फॉर एग्जाम्पल कभी ऐसा होता है कि जैसे एक आईपी पेशेंट है, आईसीयू का पेशेंट है या फिर आईपीडी पेशेंट है, वो अगर डायलिसिस में आके डायलिसिस कर रहा है, जिसको जो है डायलिसिस टेक्नीशियन क्या करता है सबसे पहले, तो उसको बेटाडिन से और स्पिरिट से साफ कर रहा है। तो ये टेक्नीशियन को ये पता होना चाहिए कि व्हाट इज बेटाडिन और व्हाट इज स्पिरिट। मोस्ट ऑफ द टेक्नीशियन यूं समझते हैं कि जैसे स्पिरिट इट्स ए एंटीबैक्टीरियल एजेंट या फिर कोई बैक्टीरिया किल कर रहा है, जबकि ऐसा नहीं है। ये टेक्नीशियन को पता होना चाहिए कि बेटाडिन जो होता है, बेटाडिन लगाने के बाद उसको एक 5 मिनट्स के लिए छोड़ा जाता है ड्राई होने के लिए, जब जाके कैथेटर की जो ऊपर है जो बैक्टीरिया लगी हुई हैं, जो वायरस लगा हुआ है, वो किल हो जाता है। और स्पिरिट जो है वो ओनली रिमूवल ऑफ एंड जो बैक्टीरिया जो वायरस जो किल हुआ है उसको रिमूवल का काम कर रहा है स्पिरिट। मोस्ट ऑफ दी हॉस्पिटल्स में डायलिसिस में देखा गया कि बेटाडिन का इस्तेमाल नहीं होता है, डायरेक्टली स्पिरिट का इस्तेमाल किया जा रहा है, जहाँ पे बैक्टीरिया किल हो रहा नहीं है, और एट द टाइम ऑफ कनेक्शन जो है बहुत सारे बैक्टीरिया वायरस बॉडी के अंदर निकल जाता है। तो यहाँ पर भी ये ज्यादा चांसेस है। और बहुत सारे रीजंस में एक वजह ये भी है कि हॉस्पिटल, इनका जो हॉस्पिटल जो स्टे होता है डायलिसिस पेशेंट का, ये फ्रीक्वेंट ज्यादा रहता है कि कभी कुछ इन्फेक्शन के लिए स्टे होना पड़ रहा है, कभी कैथेटराइजेशन के लिए स्टे होना पड़ रहा है। तो हॉस्पिटल का जो एनवायरनमेंट रहता है, जैसे हेल्थ जो है हॉस्पिटल एक्वायर्ड इन्फेक्शन के चांसेस यहाँ पे ज्यादा रहती है। ये किससे होता है? ये हेल्थ केयर वर्कर से स्प्रेड हो सकता है, मिस हैंडलिंग ऑफ पेशेंट। इसलिए कि जो मेन जो सोर्स है जो इन्फेक्शन होने का डायलिसिस पेशेंट टू डायलिसिस पेशेंट में, वो हेल्थ केयर वर्कर है। एक हेल्थ केयर वर्कर अगर डायलिसिस पेशेंट को हैंडल कर रहा है, किसी ग्लोव्स को यूज करके जो है किसी पेशेंट को उसने इस्तेमाल किया, प्राइमिंग किया, वॉशिंग किया, टर्मिनेशन किया, कैनुलेशन किया, उसी ग्लोव्स से जो है वो निकालने के पहले या फिर जो है इमरजेंसी कोई और मशीन पे अलार्म बज गया, तो ये जो टेक्नीशियन है उसी ग्लोव्स से जो है कोई और मशीन पे लेके जाके जो है मशीन को टच करता है। क्योंकि जहाँ पे हम मशीन की अगर हम बात कर रहे हैं, तो मशीन की सरफेस में जो फ्रीक्वेंटली टच होने वाले जो बटन्स हैं या फिर जो टैप्स हैं, जो जहाँ पे हम फ्रीक्वेंटली टच कर रहे हैं, यहाँ पे ये बैक्टीरिया या फिर वायरस है या फिर कोई भी एचसीवी एचबीसीजी वायरस लग गया, तो जबकि हमारे ग्लोव्स पे वो वायरस लगा हुआ है। तो ये क्या होता है कि जब हम दूसरे पेशेंट को जब हम कैनुलेशन करने जाते हैं, तो वो हम सोर्स बनते हैं कि एक पेशेंट का इन्फेक्शन दूसरे पेशेंट को लेके जाके हम दे।
Mr. Ali, I am so sorry actually interrupting you.
Okay.
Could you go to the technical, because I think we have paucity of time. If you could
Okay.
shorten it to
तो अगले पॉइंट्स में मुझे बढ़ना है कि एचडी डायलिसिस मशीन में मोस्टली जो है बायोफिल्म्स का फॉर्मेशन होता है, ड्यू टू जो है उसमें बाइकार्ब सक हो रहा है और बाकी इलेक्ट्रोलाइट्स उसमें सक हो रही हैं जो हम एपी पार्ट के थ्रू हम देते हैं। तो इसको फ्रीक्वेंटली हमें डिसइंफेक्शन करना बहुत ज्यादा जरूरी है। इसलिए कि डायलिसिस मशीन अगर हमारा डिसइंफेक्शन नहीं होता है तो वहां से भी हमें इन्फेक्शन होने की चांसेस ज्यादा बढ़ती हैं। जैसे कि जो उसमें कैल्शियम है या फिर अदर सॉल्ट डिपॉजिट हो रहे हैं मशीन के अंदर, फ्रीक्वेंटली ईच डायलिसिस पेशेंट के बाद में हमें डिसइंफेक्शन करना जरूरी है। इसलिए कि शॉर्ट टाइम होता है कि यूजुअली क्या होता है कि रिंस करके देते, डिसइंफेक्शन होता नहीं है, मशीन पूरी डिसइंफेक्शन होती नहीं है, जिसकी वजह से इन्फेक्शन के चांसेस हमारे यहाँ पे बढ़ जाता है। और उसमें दूसरा रीजन ये भी है कि जो आरओ वाटर का जो हमारा जो प्रोडक्ट वाटर है, जो वो भी एक सोर्स ऑफ इन्फेक्शन है। अगर फ्रीक्वेंटली डायलिसिस का जो अपना जो आरओ प्लांट है, आरओ उसको जो बैकवॉश देना है, रीजनरेशन देना है, फिल्टर चेंज करना है, ये भी बहुत बड़ा मेजर सोर्स है। इसलिए हमें फ्रीक्वेंटली बैकवॉश देना है, फ्रीक्वेंटली रीजनरेशन करना है, फ्रीक्वेंटली हमें जो फिल्टर चेंज करनी है, एंडोटॉक्सिन के लेवल चेक करनी है, और वो जो एंडोटॉक्सिन है वो आर्मी स्टैंडर्ड्स के अकॉर्डिंगली हमारे होने चाहिए। और जो कॉलोनी फॉर्मिंग यूनिट जो बनती है वाटर में, वो भी हमारे आर्मी स्टैंडर्ड के अकॉर्डिंगली हो। और इसके अलावा जो है एक रीजन ये भी होता है कि जैसे हाउसकीपिंग है, हाउसकीपिंग का जो स्टाफ है मोस्टली जो है ये तो बहुत ज्यादा अनअवेयर होता है कि कहाँ पे हमें टच करना है। हाँ, कोई अगर हम कोई कोई चीज है, लाइनिन को किस तरह से हमें हैंडल करना है, बेड को किस तरह से हमें वॉश करना है, या फिर जो है डायलिसिस मशीन को हमें टच करना ही नहीं करना है, ये मोस्ट ऑफ द जो हाउस कीपिंग स्टाफ है इनको ये चीज पता नहीं होती है। तो इसलिए जो है ये डायलिसिस टेक्नीशियन या फिर हेल्थ केयर जो वर्कर्स हैं उनका ये काम है कि डायलिसिस मशीन के सरफेस क्लीनिंग को सबसे ज्यादा ध्यान देना है, जिसमें जो है हम जो क्लिनिकल जो सॉल्यूशंस है उसको हमें इस्तेमाल करके हमें मशीन को बैक्टीरियल और वायरस फ्री करना है, क्योंकि बैक्टीरिया तो ये मेजर सोर्स है इन्फेक्शन का, जिसमें जो है क्योंकि जैसे अगर हम डायलिसिस मशीन के अंदर अगर हम बाइकार्ब हम रख रहे हैं, और बाइकार्ब हम क्या बना, क्योंकि बाइकार्ब हमेशा फ्रेश बनता है कंपेरेटिवली, जो अगर हम ए पार्ट तो हम पहले से बना के रख सकते हैं, लेकिन बाइकार्ब जो होता है वो मोर देन अगर 6 आवर 8 आवर्स अगर होता है तो देयर विल चांसेस ऑफ ग्रोइंग द बैक्टीरिया इन द बाइकार्ब, बिकॉज द बैक्टीरिया के लिए बाइकार्ब एक मेजर सोर्स है पनपने का। इसलिए जो है हमें जो बाइकार्ब का जो सिस्टम है वो फ्रीक्वेंटली हमें वॉशिंग में रखना है, जैसे कैंस हैं जिसमें हम बनाते हैं, और इसके अलावा जो है हम जिस वक्त हम इस्तेमाल करना है जब भी हमें बाइकार्ब बनाना है। जैसे कि यहाँ पे कहा गया कि एक्सपेरिमेंटल स्टडीज हैव शोन दैट lactonic floating bacteria can evolve into the fully mature biofilms, colonies that are extremely resistant to biocides, and shed lactonic bacteria with 3 to 4 days। इसमें क्या होता है कि अगर इसको हम ज्यादा देर तक हम डिसइंफेक्शन नहीं करेंगे तो एक बायोफिल्म ऐसी तैयार होती है जिससे जो है नॉर्मली रिंस से ये बैक्टीरिया जो है निकलता नहीं है। डेवलपमेंट ऑफ बैक्टीरिया बायोफिल्म इन द हाइड्रोलिक सर्किट of hemodialysis machine can be prevented by the frequent use of chemical and heat disinfection strategies। Usually होता ये है कि at the end of the day dialysis machines को disinfection किया जाता है, but according to standard protocol each dialysis patient के बाद में हमारा machine disinfection हो जाना चाहिए। तो हॉट स्टेरिलिएंट या फिर हॉट डिसइंफेक्टेंट से हमें क्या फायदा हो रहा है, इसमें यह होता है कि जो हमारे मशीन के अंदर जो स्केलिंग डिपॉजिट हुआ है वो ठीक से निकल जाएगी, और डीकैल्सिफिकेशन होता है क्योंकि कैल्शियम की एक लेयर जो बनती है वो जो है आफ्टर डायलिसिस में निकलना जरूरी है, और डिसइंफेक्शन ऑफ डायलिसिस मशीन जो है साइमल्टेनियसली हमारा हो जाना चाहिए। ये जिसमें जो है बायोफिल्म्स में निकले कैल्शियम है, मैग्नीशियम का डिपॉजिट वो सही टाइम पे निकलता रहे, और पूरा डिसइंफेक्शन हुआ या नहीं है ये ईच है टेक्नीशियन की जिम्मेदारी है। कोल्ड स्टेरिलेंट फॉर हेमोडायलाइजर एंड ब्लड लाइन्स, जैसे कि जो है डायलाइजर के लिए और जो ट्यूबिंग के लिए जो केमिकल इस्तेमाल किया जाता है जैसे रेनाक्लिन है, उसका सही से परसेंटेज होना बहुत जरूरी है, एटलीस्ट 3.5 to 4% का इसमें होना जरूरी है, ताकि जो है जो हम उसमें जो रेसिडुअल इफेक्ट ज्यादातर रहे, क्योंकि एक डायलिसिस पेशेंट का अगर वाइकली ट्वाइस आ रहा है, थ्राइस आ रहा है, जब तक उसका डायलाइजर जो है जितना ज्यादा हमारे यहाँ पे स्टोरेज रहेगा उतना वो जो स्टेरिलेंट जिसमें हमने रखा है उसका पावर जो है कम होता रहेगा, और जितना कॉन्सेंट्रेट रहेगा उतना जो है उसका पावर रहेगा, और आइंदा नेक्स्ट डायलिसिस तक के लिए उस डायलिसिस में वो डायलाइजर में या फिर उस ट्यूबिंग के अंदर कोई बैक्टीरियल या फिर वायरल ग्रोथ नहीं होगा। कोल्ड स्टेरिलेंट रिएक्ट जो करता है वो जैसे प्रोटीनिश मटेरियल है, जैसे कि डायलाइजर के अंदर जो मेनली जो बचता है वो पेशेंट्स का रेसिडुअल ब्लड बचा हुआ है या फिर उसमें प्रोटीनिश मेटल बचा हुआ है, उसको अगर हमें हाइड्रोजन पेरोक्साइड है या फिर रेनाक्लिन है, इससे सही से क्लीन करना और सही से इसको डिसइंफेक्टेंट्स में फिल करके हमें स्टोरेज करना ये बहुत ज्यादा जरूरी है डायलिसिस के अंदर। और मोस्टली जो ट्यूबिंग हम रेकमेंड करते हैं सिंगल यूज करके उसको हमें डिस्कार्ड कर दे रहे हैं कि ओनली बिकॉज ऑफ जो है ये फाइनेंशियली सबके लिए अफोर्डेबल नहीं होता है कि इंडिया में, इसलिए इस चीज को ज्यादा रीयूज किया जाता है, लेकिन रीयूज अगर किया भी जा रहा है तो इसको सही से स्टेरिलेंट सही से डिसइंफेक्शन करना बहुत जरूरी है। और इसके अलावा जो है हमें कुछ चीजों का ध्यान ये भी रखना है कि जो हमारे यहाँ पे जो वेस्ट प्रोडक्ट जो निकलता है हमें उसको सही तरीके से, जैसे कोई माइक्रोवेल वेस्ट है, सॉलिड वेस्ट है, उसको किस तरह से हमें डिस्कार्ड करना है, कहाँ पे इसको डालना जरूरी है, सारी चीजें सही से सेग्रीगेट करके हम रखेंगे तो इन्फेक्शन के चांसेस हमारे डायलिसिस सेंटर में बहुत कम रहती हैं। मोस्टली क्या होता है कि ये सारी चीजें जो माइक्रोवेल वेस्ट है, कोई नीडल है, शार्प्स है, मेडिसिन है, केमिकल वेस्ट है, ये एक ही में सब जमा हो जाती है, जिसकी वजह से जो है जो हाउस कीपिंग स्टाफ है उनको इन्फेक्शन की चांसेस रहती है, एनवायरमेंटल इश्यूज हो जाती हैं। इसलिए हमें जैसे येलो बिन है, रेड बिन है और ब्लैक बिन है, ग्रीन बिन है, यानी जिस बिन में जो वेस्ट हमारा जाना चाहिए उसको सही वक्त में सही से डिस्कार्ड अगर किया जाए तो ज्यादा इसमें बेहतर ये होता है कि हमें इन्फेक्शन ना, इसमें एक होता है कि बैरियर नर्सिंग, यानी इन्फेक्शन हमारे इन्फेक्शन किसी और को ना हो और पेशेंट के इन्फेक्शन हमें ना हो। इसलिए जो है ये सेग्रीगेशन ऑफ बायोमेडिकल वेस्ट करना बहुत ज्यादा जरूरी है। डायलिसिस के रिगार्डिंग, डायलिसिस सेंटर के रिगार्डिंग अगर कोई क्वेश्चन रेज करना चाहते हो तो आप बिल्कुल पूछ सकते हो। वेलकम हियर।
Thank you very much, Aliji. It was a wonderful presentation. Because of the paucity of time, I think we will be able to take only a few questions. Maybe before I let you go, one of the questions, the people are asking is, what is the frequency of internal machine cleaning?
Okay. एक्चुअली मैंने जैसे कहा कि स्टैंडर्ड जो प्रोटोकॉल है, ईच डायलिसिस सेशन के बाद में हमारा डिसइंफेक्शन होना जरूरी है। ओनली बिकॉज ऑफ टाइम कंज्यूमिंग प्रोसेस होने की वजह से डायलिसिस टेक्नीशियन क्या करते हैं कि एक पेशेंट के बाद में दूसरे पेशेंट के बिटवीन में ओनली रिंस दिया जाता है, जिसमें कोई बैक्टीरियल अगर कंटेमिनेशन हुआ है, वायरस कंटेमिनेशन हुआ है तो ये फुली पूरा क्लीन होता नहीं है। बट टाइम कंज्यूमिंग प्रोसेस होने की वजह से ये किया नहीं जाता है, जिसकी वजह से हमारे इन्फेक्शन के रेट ज्यादा बढ़ने लगते हैं। तो ईच एवरी सेशन के बाद में हमारा डिसइंफेक्शन होना बहुत ज्यादा जरूरी है।
So what should be the time required for cleaning one machine at any given time?
मिनिमम जो क्लीनिंग का जो टाइमिंग है वो है एटलीस्ट मिनिमम 50 मिनट्स टू 20 मिनट्स का टाइमिंग होता है। अगर आपको टाइम कंजम्पशन मतलब जो कंज्यूमिंग जो प्रोसेस है वो सही कम करना है तो आपका जो सर्विस जो मशीन का जो सर्विस इंजीनियर है, बायोमेडिकल जो इंजीनियर होता है, अगर हम उसको बता देंगे भी हमें एक शॉर्ट टाइम का डिसइंफेक्शन चाहिए तो वो आपको सेट करके देंगे कि इतने शॉर्ट टाइम का कम से कम आपको विद इन 15 मिनट्स या 10 मिनट्स में आपका डिसइंफेक्शन एटलीस्ट हो सकता है। फास्ट डिसइंफेक्शन जिसको कहा जाता है, इंटरमीडिएट।
Thank you so much, Aliji. Dr. Shoaib, if you are around, there are many questions, but I would not actually probe you with all of them. Maybe at least a couple of those questions, maybe you could address. What is the frequency of testing for HIV, HBsAg, and HCV for a CKD patient routinely coming for dialysis?
Yeah. See, routinely coming for dialysis, the frequency recommended is once in 6 months. But what we generally practice is once in 3 months. And second thing is once a month, it is always good to check the SGPT levels. Because in case the person is getting infected with hepatitis B or hepatitis C, then the SGPT levels may show a surge. And that's the time to check the viral load. So the more frequent, the better. 3 months is what we follow. And once in 6 months is the international recommendation. Because we are using reuse policies, all these stuffs are there. So the chance of infection goes up.
But according to the protocol, it is 6 months. Once in
6 months, yeah, that's in 6 months.
It is only...
Titers also once a year. If hepatitis B vaccinated, the titers are more than 100, then you check it once a year. Yeah.
Sure, doctor. And one more question, which is a very common question, which is asked by many people, is which are the most common infections among the dialysis patients?
Dialysis patients, just like any other population, all infections are more common. But as we have discussed, the most common infection is the line infection, the catheter infection. Unfortunately, because of the inadequate training of the patient's mentality that they look for a cure for CKD, that they deny to make a fistula when they're in stage 4 and ultimately end up crash landing to a hospital ICU. See, ICUs are not built for this stuff. So they come in an ICU, they get an infection, they're in the line. Second, they come to an ICU, they get opportunistic infections, pneumococcal infections also they get. So these two are most dangerous. Line infections are common, followed by opportunistic lung infection, especially pneumococcal, which can be prevented. All these can be prevented. Unfortunately, it's not happening now. Probably with your efforts, sir, in the future, we'll see these infections coming down drastically. Hope so.
Sure, I think we should try. I think we are all in that fight together to reduce the infections, and more of these sessions. I am hopeful that they are going to improve the knowledge levels and improve the practices within our settings.
True,
and of course, as we told in the beginning itself, the incidence and the frequency of the CKD patients, the prevalence is increasing, which is becoming a big burden, both economically and also otherwise. I think we should strive actually to minimize those infections. But because of the paucity of time, I would not actually quiz you more. Some of these questions, if possible, I would send it by mail so that
Yeah. I'll type my mobile for you.
We can send the answers to the people, because post this session, anyhow, we would be sharing the recording and also the presentation. Along with that, probably we can share the answers to all those questions, which have been raised. Thank you so much. After Diwali, you made actually one more Diwali, Dr. Shoaib and
One point here, sir. In the talk, I have mentioned that dialysis patient need not need a contact precaution wrong. That's the slip of the tongue. I'm really sorry. And it's a big mistake. Sorry on that. They do need. Yeah.
Thank you. Thank you so much. And we will catch up once again for the next session.
Thank you, sir. Thank you. Great.
Mr. Lalit, if you could actually take down all these questions and send these questions and answers to all our participants today, I would be grateful.
Thank you, sir. Bye.
Thank you very much. And we'll catch up again next week, same day, same time, and at another session we will have. Thank you.
Thank you, sir.
Okay, thank you so much. It's a pleasure for us. Okay.
Yeah.
Thank you.
Thanks, everyone.
Thank you, everyone. Thank you very much for your time.
Bye.
Thank you, sir.